One of the most catastrophic fatal complications with a very high mortality rate, air embolism, the nightmare of hysteroscopic surgery. In the coming video, let us share a case complicated by air embolism during myoma resection. We will see together, step by step, how and why did it happen. The case was just a simple myoma resection in a patient, old age, 68 years old, postmenopausal bleeding. And the demonstration was one of the workshops in a country. And here we start by going through the cervix, demonstrating the characters of endocervical mucosa, and I was explaining how to enter the uterine cavity, the oval shape internal os, and glide on the anterior wall, gently and easy. Don't go quickly. Give a chance for the water to go before you. The distension medium was saline, and I was using the 26 French bipolar resectoscope. The myoma is average, is not big. I can say it's something like 2.5 to 3 centimeters, and the location is fundal. Here we explore together the boundaries of the myoma. There's a small, tiny seedling myoma on one side. Here I'm using the electrode to touch and try to move the myoma to estimate the attaching pedicle. Is it broad or just type 0? I can say this is like type 1. Well, everything was going fine, and then I started the resection, adjusting the bipolar power to test how the electrode is gliding. Now you can see showers of bubbles, gas bubbles. And this is a phenomena that I observed, especially in using bipolar, which is very less to happen with monopolar. We know that monopolar risk is the danger of using glycine, the non-electrolyte solution. That's why everybody escaped from using it. I do agree upon that. But on the other side, you see the showers of gas bubbles. I'm gonna play this small part with slow motion, so you can see how the bubbles are swept, travel, and go at the base of the myoma. The danger of air embolism is catastrophically more when the myoma is anterior wall. Because if the myoma is anterior wall, this means that the raw surface is anterior and the bubbles travels and floats anterior. That's why the absorption, I wouldn't say absorption, the sucking of gas bubbles is more dangerous. So actually, I didn't give much attention to these showers of bubbles. I thought it's minimal and it would not affect the patient or compromise the patient life. You can see here that after some strokes of resection, I could see this is the base, the myometrium, and we have a small bleeding vessels. So hemostasis here is just to secure, to avoid staining of the distension medium with red blood. Otherwise, you will be operating in a red wine or strawberry juice. So once you see this bleeding, you should realize that the intrauterine pressure is less than the vascular pressure. The arterial blood pressure is like 100 or 120. But if you have a bleeding, this means that you don't have a tamponade effect. Again, another bleeder. But still, I was not worried or aware that there is suction of gas bubbles through this open vascular channel. So, working with a little bit higher pressure, which exceeds the vascular pressure, again, is the mainstream teaching that a high blood pressure will cause volume, fluid overload. This is a very naive thinking, because the high pressure will not push the fluid through open vascular channel. On the contrary, it will compress, tamponade, and close the blood vessels. So here I was operating outside of my place. I was using a standard pump, which does not provide higher pressure. That's why I could have this bleed. It's still, you have some open vessels You can see the mouth of the bleeder. Don't panic. Come close, and touch, and then push the pedal of coag to secure this blood vessel. And keep on resecting. Air embolism is known as the catastrophic fatal complication happening when a bolus of gas or air get into vascular channels and to the pulmonary tree, obstructing the exchange of carbon dioxide and oxygen. So this leads to hypercapnia and catastrophic complication. I will explain what happened. Here, with a slow motion, you can see the gas bubbles getting swept, sucked up into the space or the cavity of the myoma. And this is aggravated because of the position of the myoma in the anterior wall. Here, this is the most important clip showing the bubbles getting swept up. Look at this shower of bubbles. This occurs when activation the bipolar current, a phenomena which deserve attention from experts, from industry and manufacturers. How far the safety of using the bipolar. Here is a backhand movement trying to detach last piece of everything was going smooth, and I was explaining to the audience. There was a live transmission and people watching, and I was explaining that don't go in and out, stay inside. Sometimes I use a forehand movement to cut into the myoma, and in other parts I use a backhand movement to detach, like in this area. Vital signs were stable. One more advice I tell you: when you are operating, let your ear to follow the beeping sound of the monitors, the heart rate. Every now and then, look at the vital data on the monitor. Don't leave the anesthetist alone to take care of all that. Still, we have some open vascular channels and bleeding. This means again that the intrauterine pressure is lower than the pressure inside the open vessels. In my personal opinion, if you increase the fluid pressure, it will tamponate the vessel. Look at the bleeder here. Tamponating the vessels might carry, by high pressure, might carry a little risk of fluid overload, but outweigh the risk of fluid absorption and possibility of air embolism and compromising the field of view and getting a messy, bloody view. People get panicked thinking that this is dangerous. Now I stopped because I realized there is a beeping sound of heart rate going down, 60, 40. The heart rate went down to 14. There was a panic in the operating room. The anesthetist immediately recognized it is air embolism, so immediately putting head down, hyperbaric oxygen, and our hearts were pounding very strongly because the heart rate of the patient was going down, down, down. Imminent arrest because of the immediate management of the anesthetist. Again, head down, hyperbaric oxygen, and everybody in the operating room was standing on their toes. It was a terrible moments. It was a scary moments. I hope nobody will feel it when you hear the beeping sound going down, down. Heart rate was 50 here, but it went down to 14. Every second went like 1 year. We were waiting, expecting what will happen. And gradually the heart rate starts to rise up, hyperbaric oxygen, head down, and then patient transferred safely to the recovery room, and mission accomplished. This is Osama Shawki from Cairo, Egypt.